Dr. Baliga here. This is the second podcast on cultural competency in the doctor-patient relationship, derived from an outstanding chapter written by Dr. Horace M DeLisser, MD, who is Associate Dean for Diversity and Inclusion and Associate Professor of Medicine and Pulmonologist at the Perelman School of Medicine at the University of Pennsylvania. The chapter is in Baliga's Textbook of Internal Medicine, available at www.mastermedfacts.com. This podcast will discuss some of the key elements in cultural competency. A real-life scenario. You're seeing a patient for the first time. Patient name is Ana Cortes, a 35-year-old El Salvadorian immigrant who has come to you for primary care. She speaks Spanish, and it is immediately evident that she understands very little English. She has her 12-year-old son with her who speaks and understands English. What should you do for language interpretation for this patient? A. Evaluate her best as you can as she is in need of primary care. B. Use a telephone interpretation service. C. Have her son provide the interpretation. D. See if any of the staff speaks Spanish. And E. Reassign her to a colleague who speaks Spanish. At the end of the podcast, we'll discuss the best option. Key elements of cultural competency. For healthcare providers, cultural competency is understood as involving three elements: self-awareness, development, and refinement of cross-cultural communications and negotiation skills, and thirdly, knowledge of cultural norms and health disparities. Furthermore, it is necessary to see the acquisition of cultural competence as an ongoing process rather than an isolated single event, such as listening to a lecture or taking a course. Ongoing self-awareness. Three things are involved in self-awareness necessary for cultural competence. The first is an emerging recognition of one's own cultural influences, including the culture of medicine, as well as personal biases and prejudices. The second includes an appreciation of those culturally based factors that trigger anxiety, anger, fear, or discomfort. Lastly, the acknowledgement of these issues requires humility and an openness to the possibility of a need for growth. This is necessary because the initial cognitive response is often to deny the presence or even the possibility of personal bias. The awareness of unconscious bias, more often than not, emerges out clinical encounters and experiences that challenges or expose unexamined attitudes, thinking, or beliefs. Unfortunately, tools for proactively identifying personal unconscious bias are limited. In this regard, the most widely used test for assessing unconscious bias is the Implicit Association Test, IAT. It's a computer-based interactive test that determines the time it takes to match words or pictures corresponding to a social group, that is race, gender, age, body size, to paired opposing characteristics, pleasant versus unpleasant, good versus bad. The test assumes the less time will be taken to match a group word or picture to a characteristic if the person taking the test already associates the social group with the characteristic, compared to when there is little or no association of the social group with a particular characteristic. Although widely cited in literature, the validity of this tool has been debated, and the significance of changes in a person's score is unclear. In addition to learning from personal experiences, meaningful cultural self-awareness must also be facilitated on an individual level by ongoing, intentional efforts. These include narrative writing and journaling about clinical and professional experiences as vehicles for reflection, exposure to a variety of culturally informing literature and media, and discussion of these issues with trusted peers. The next important element of cultural competency is ongoing development and refinement of cross-cultural communication and negotiation skills. There are at least 4 communication skills that are pertinent to cultural competency, including, firstly, eliciting the patient's understanding of the meaning, significance, and impact of her or his illness. Secondly, effective use of language interpreters. Thirdly, communicating with patients with limited English language proficiency. And finally, appropriately engaging culturally insensitive peers. Eliciting the explanatory model of illness. Patients bring to their physician encounters beliefs about the causes, meanings, and significance of the illnesses, as well as expectations about their therapies and treatments. These beliefs, described collectively as the explanatory model, are shaped to varying degrees by their cultural backgrounds and experiences. Knowing and understanding the explanatory model of the patient enable more effective communication and facilitate discussion and negotiation about the plan of care. A number of approaches for cross-cultural communication, along with mnemonics for remembering them, have been described for eliciting the patient's explanatory model. As a group, they emphasize the importance of 1. Curious, attentive, respectful, non-judgmental listening. 2. Patience. 3. Open-mindedness. 4. Humility. 5. Empathy. And 6. A willingness to compromise, negotiate, and collaborate with the patient. The patient's explanatory information may be formally obtained in a single conversation. However, more often than not, it will be captured over several encounters, with the physician being alert for opportunities during conversations with the patient to use open-ended questions to learn about the beliefs and expectations of the patient. Some mnemonics for cross-cultural communication include 1. Learn, where L is listen, E is explain, A is acknowledge, R is recommend, and N is negotiate. The second mnemonic is ethnics. E is for explanation, T is for treatment, H is for healers, N is for negotiate, I is for intervention, C is for collaborate, and S is for seniors and spirituality. ESFT is the third mnemonic, where E is for explanatory model of health and illness, S is for social and environmental factors, F is for fears and concerns, and T is for therapeutic contracting. The final mnemonic is restore, where R is for respect of the journey and or the experience of the patient, E is for engage them, that is listen with the intent to be influenced, S is for sensitivity to the patient's perspective, T is for teach them your perspective, O is for open-mindedness, R is for reach common ground, and E is for exercise humility. The mnemonic again is restore. Use of language interpreters. Although there are circumstances where it cannot be avoided, the use of untrained family members or friends to provide language interpretation may present a number of problems and thus is not encouraged. Specifically, there is compelling evidence of risk for error, filtering, editing, and distortion when family or friends are used as interpreters. Particularly problematic are instances in which pre- or early adolescent children interpret for a parent or adult relative, limitation in the educational or language capacity of the child, and potential awkwardness for the adult in revealing embarrassing or private information represent some of the concerns over using a child in these settings. Given this, a trained individual, either in person or via an online or telephone service, should be employed to provide the interpretation services. A number of things are recommended to effectively use an interpreter, particularly when the person is untrained. First, have a pre-interview discussion with the interpreter. For the trained interpreter, provide a brief summary of the clinical situation and the purpose of the interview, while the untrained individual should be instructed to interpret as best as possible, word for word, and to not paraphrase, summarize, or edit what is being said. Second, the interpreter ideally should be positioned behind and slightly to the side of the patient. Third, during the conversation, the physician should make eye contact with the patient and not the interpreter. Experienced interpreters will in fact avoid eye contact so as to further facilitate the interaction between the patient and the physician. Finally, speak in first person using I and in short sentences, being careful to minimize the use of jargon, phrases, or references that may not translate as well from English into another language. Although the value and importance of language interpretation in the clinical setting is unquestioned, it is important to appreciate some of its potential limitations. Although compelling clinical, professional, and even legal reasons exist for providing interpretation services, admittedly, there can be both financial and logistical challenges in providing these services. Regional dialects and the fact that some English words may not translate readily or at all into another language are a further set of challenges. In addition, the barrier of language along with the presence of the interpreter unavoidably tends to suppress some of the purely social and spontaneous interactions that are more likely to occur between the physician and the patient when they are able to communicate directly with each other. This is important for some groups, and its absence may diminish the satisfaction with the clinical experience. Communicating with patients with low English language literacy, an extensive body of literature has established a strong association between literacy and health. In fact, literacy is a better predictor of an individual's health status than education, income, employment status, age, race, or ethnicity. Further, low literacy increases the risk of dying from communicable and chronic diseases. This is not surprising given the low literacy undermines the ability of patients to follow instructions, take prescribed medications, understand disease-specific information and prevention strategies, and exploit online resources to facilitate self-management. In addition, insufficient literacy may prevent individuals from completing required forms and thus keeping them from seeking and obtaining healthcare services to which they are entitled. Low literacy is generally more common among racial and ethnic minorities, the poor, and those who are mentally or physically challenged. It's also more likely in the elderly due to declining vision, reduced hearing, and a loss of mental alertness. It is important to stress, however, that patients with low literacy are generally not immediately identifiable and can be quite articulate while being limited in their writing and reading skills. The difficulty in recognizing patients with low literacy arises from the fact that these individuals can become very adept at hiding their limitations, using strategies such as avoiding situations that require reading or writing, forgetting their glasses, or turning to family and friends for help. Thus, unless there is obvious evidence to the contrary, it is prudent to never initially presume that the patient is literate. Indicators suggestive of low literacy include forms of questionnaires that are uncompleted or illegibly or incorrectly completed. Secondly, frequent missed appointments. Thirdly, failure to follow through on scheduled tests or procedures. Fourthly, poor adherence. Fifthly, inability to name medications or describe the reasons for taking them. Next, identification of medicines by opening the bottle and looking at the medications rather than reading the label. And finally, when asked to read or complete forms, the patient responds, "I forgot my reading glasses," or "I need to take this home to show it to my wife, husband, or children." If it is suspected or independently confirmed that the literacy of the patient is low, directly confronting the patient about this is not likely to be helpful. Instead, this understanding about the patient should be factored into the way information is presented to the patient. Strategies that can be employed for patients with low literacy and for all patients as well include communicate with the patient on a basic level without using medical jargon, provide patients with opportunity to tell their story without interpretation, assess comprehension by using teaching back method and by asking questions that begin with what and how, limit the number of new concepts to no more than 3 during each visit. For demonstration, use pictures, graphics, or actual devices. And finally, present information orally using written material primarily as backup. Particularly effective is the teaching back method, where patients are asked to restate in their own words the instructions or directions that have been given to them. Engaging colleagues around issues of cultural insensitivity. Responding to colleagues or other healthcare providers who make remarks or demonstrate behaviors that appear to be culturally insensitive can be a challenge, particularly when there is fear of being charged with political correctness. However, as professionals, we need to raise the expectations for our conduct and thus seek to police ourselves. It would be naive to suggest that there is a best way to engage a culturally insensitive colleague. Undoubtedly, the way the conversation is initiated, along with the timing and location of it, will necessarily have to be tailored for each situation. With that in mind, however, an approach that is likely to be effective is one that A. assumes goodwill on the part of the other person, B. is not accusatory, and C. targets the offending words or actions and the reactions they triggered. The next important element of cultural competency is the ongoing acquisition of knowledge of cultural norms and health disparities. Rather than seeking an encyclopedic knowledge of all things cultural, the primary goal is to become knowledgeable about the history, cultural beliefs, values, and experience of the populations one regularly treats. In addition, as is done generally in clinical medicine, interesting, challenging, or frustrating cultural encounters should serve as prompts to learn more. Sources of relevant information include web-based content and curricula, national conferences, and case-based resources. However, in many instances, asking and learning from patients themselves is the best place to begin to obtain this kind of cultural information. Other resources for cultural information include cultural brokers such as chaplains and social workers. Further, experiences and opportunities to take physicians out of the clinical setting and into the communities of their patients are powerful vehicles for gaining cultural knowledge of these patients. Stereotyping versus generalizations. In making use of group-specific cultural information, it is important to distinguish between stereotyping, that is, the false and dangerous assumption that everyone is similar in a given culture, and generalizations, awareness of group norms. Generalizations provide a potential starting point for understanding the patient, but do not exclude the influence of other factors specific to the patient, such as education, acculturation, nationality, and other competing cultural factors as well as personal beliefs. So while knowledge of group norms is helpful, it is more important to develop cross-cultural communication skills that enable the physician to engage each patient as an individual with their own cultural and social experience. Thus, while it may be useful to know that some African Americans are distrustful of physicians, it is much more valuable to learn signs of distrust and develop the skills for establishing, nurturing, and sustaining trust. Health disparities. Cultural competency also includes knowledge of health disparities that are pertinent to the physician's area of practice or the patient populations and that the physician regularly sees. The information is then used to inform the care provided to these patients. Although the definition has evolved somewhat, health disparities now refer to differences in the incidence and prevalence of health conditions and health status between groups that are closely linked to social, economic, and/or environmental disadvantage. The most health disparities affect groups that have historically experienced exclusion or discrimination because of race, ethnicity, socioeconomic status, sexual orientation, gender, geographic location, disability status, or a combination of these. These health differences, in turn, place those in disadvantaged groups at a further disadvantage. The causes of disparities are complex, multiple, interrelated, and vary from one disparity to another. This is illustrated, for example, by prostate cancer. For this malignancy, blacks have a greatly higher incidences and mortality compared to all other racial and ethnic groups. In contrast, Native Americans, a group that has been uniquely disadvantaged, have incidence and mortality rates for prostate cancer that are well below those of whites. The processes that generate disparities include biological factors, particularly epigenetic processes, culturally based beliefs and preferences of individual patients, the quality of patient-provider interactions, differential access to health care, institutional and governmental policies, and socioeconomic factors. Included among socioeconomic factors are differential living and working conditions in homes and communities, as well as differential access to economic and social opportunities and resources. This suggests that while training focused on healthcare providers is important and necessary, reduction or elimination of health disparities require interventions that go beyond patient-provider interactions to also target governmental policy decisions, the culture and values of healthcare institutions, and the social determinants of health. Going back to the case discussed earlier in the podcast, I repeat, you're C for the first time, Ana Cortes, a 35-year-old El Salvadorian immigrant who has come to you for primary care. She speaks Spanish, and it is immediately evident that she understands very little English. She has a 12-year-old son with her who speaks and understands English. What should you do for language interpretation for this patient? A. Evaluate her as best as you can, as she is in need of primary care. B. Use a telephone interpretation service. C. Have her son provide interpretation. D. See if any of the staff speaks Spanish. And E. Reassign her to a colleague who speaks Spanish. And the answer is B. Use a telephone interpretation service. While language interpretation is required, every effort should be made to use a trained individual, whether in person or via a telephone interpretation service. The use of family or friends is very much discouraged because of the significant risk of filtering, editing, distortion, or inaccurate interpretation by these individuals. The use of children is especially problematic due to limitations in the educational or language capacity of the child, and possible awkwardness for the adult in revealing embarrassing or private information. The next podcast will discuss specific issues of culture in the doctor-patient relationship. This podcast is derived from an outstanding chapter titled Cultural Competency in the Doctor-Patient Relationship, authored by Dr. Horace M DeLisser, MD, who is Associate Dean for Diversity and Inclusion at the Perelman School of Medicine at University of Pennsylvania, Philadelphia. The chapter is derived from Baliga's Textbook of Internal Medicine, available at www.mastermedfacts.com.